Welcome to Collegial Conversations with Diana Clark, the professional webinar series that offers clinical and personal perspectives on issues that are common, but often not talked about. Here is today's Collegial Conversation.
Thank you for joining Collegial Conversations with Diana Clark. Today, joining Diana is Dr. Amanda Wilson. Dr. Wilson is the co-founder and CEO of NorthStar Care, Inc. She has founded 3 companies in the addiction treatment space. Board certified as an addiction medicine physician, she is a thought leader in addiction treatment. In 2009, she founded CleanSlate Centers, Inc., the first national SAMHSA award-winning, physician-led, office-based clinical program for treating opioid addiction. Taking the many learnings from growing CleanSlate, she then founded Boulder Care, Inc., a national telehealth solution for opioid use disorder treatment in 2017. Inadequate options for treatment for alcohol use disorder inspired the creation of NorthStar Care, Inc., a comprehensive, physician-led, personalized alcohol treatment program. I will now hand the conversation over to you.
Thank you, Alex, and welcome, Dr. Wilson. Should I call you Amanda or Dr. Wilson? You get
Amanda would be great, Diana. Thank you. Yes.
Thank you. So, alcohol use disorder, we used to call it many things like alcoholic, drunk. There was a whole host of shaming words that associated with alcohol use disorder. But when I first started in this field, and granted I'm no spring chicken, it was really outside the purview of medicine.
Right.
It was considered a spiritual problem,
Right.
and you go to a spiritual program.
Yes, that's right.
So when did that shift?
I hope it's shifting now.
Okay.
I mean, I'll be honest, in my experience, for alcohol use in particular, it's really very much ingrained in our entire society that, if someone struggles with alcohol, that they either have, a moral inadequacy, for sure, a spiritual inadequacy, and that they generally don't care, about the consequences of their actions. And so family members are struggling, wondering why this loved one doesn't love them enough to stop drinking. And it really is time for a complete paradigm shift. Yeah.
I agree with you 100%. I think that shaming people into trying to get well when the origin of that is shame doesn't quite work somehow in my math.
The math is true. It bears out. Treatment today works at the best scenario. The standard treatment today works at 13% of people. That includes AA is 8%, detox is 10%, and rehab is 13%. So it's failing.
It is a failing system, yes. So that said, we don't have to throw our hands up and say, there's nothing that can work.
Correct.
What are you finding that works? Yeah.
Well, we took a really deep dive into the scientific literature. My co-founder has a PhD in statistics and research, and being an addiction doctor, we put our heads together. We read 2,700 papers. We read every literature, every publication in the world, actually, Australia, the US, the United Kingdom, aggregated all of that data. And there were several key things that we learned. The first is there are interestingly 30 different medications that have now been well studied to be effective in the treatment of alcohol use disorder. They're just not being used. Less than 0.4% of people who have alcohol use disorder who seek treatment, less than 0.4% of them are placed on any medication therapies.
Not naltrexone or any of those.
0.4%. Most of it's naltrexone is what's prescribed. That's exactly right. But for so few. And that's only the people seeking treatment. What's interesting is less than 8% of people seek treatment, and that's because there's nothing out there.
Yeah, there's not much out there.
Right.
I know that I want to just briefly pivot for a second of something that has been a curiosity to me. You've read all these papers internationally.
Yeah.
Are the statistics better in areas where the medical profession is more involved?
Dramatically, yeah. We really started to look very deeply at the approach they've been taking in the European Union and in the Australian health system, because they started looking at this medically decades ago, and they stopped putting people inpatient, and they started treating them at home outpatient. And they developed things like alcohol tapers at home so that you don't abruptly stop alcohol and have someone be at risk of seizures and certainly all the other things that happen. It's interesting. And, if you think about it, we don't abruptly stop anything. We don't stop blood pressure medications or antidepressant medications, right? All medications are tapered. And yet, for some odd reason, when someone wants to stop alcohol, they abruptly stop it despite the risks. There's great risks in doing
Huge risk. Yeah.
So we learned from them to taper, and they've been using medication treatments for a long time, and there just isn't the same, I'll call it basically almost a religion, the 12-step religion really in the US. I don't have any issue with the people.
Oh, for the people it works.
Terrific.
I love that. I think it's worth
Exactly.
trying because it's so available everywhere. That said, if it isn't
if it doesn't fit for you, you've got to find what does. And in general, if you're trying, this is a genetic disease. More than 50% of the reason why people develop this problem is they are genetically prone to develop it. So that's the same for hypertension. That's the same for diabetes. It's the same for cancer. So when people develop chronic medical problems, you have to address it as a chronic medical disease. I like to use an example, if it's okay, if I share this one with you. I use an example of breast cancer, right? Because it has genetic risk. People develop this, and what do they expect for treatment, right? They would expect to have an oncology doctor overseeing their care, probably have a nurse practitioner and nurses that they work with on their team. They for sure would see a nutritionist as they're facing chemo, so they would be looking at diet and nutrient therapies to support them, right? They also would be, maybe counseling for support and for family support. And then not least of all, they also would participate perhaps in a breast cancer support group, right? But people wouldn't think that the support group was really the mainstay of the treatment, right? They would think that the support group is an important augmentation to a person's rounded healing.
Sense of well-being, but it wasn't the healing, right, itself.
It's both, right? You need that healing too. But you also have to address this. You can't wait till it's stage 4. Stage 4 cancer is very hard to treat. Stage 4 alcohol use disorder, very hard to treat. So we need to try to think about getting to people a lot earlier, helping them to get control over their alcohol use earlier. And the patients who are that advanced, most of them still can be treated outpatient. 9 out of 10 patients that we're managing are people drinking more than 15 drinks a day. So they're drinking heavily, and we yet can manage them outpatient. It's very easy to do.
That's pretty amazing. Tell me how you're doing that. What is in play? You use the breast cancer analogy. Do you also have medication and nutritional support? And tell me what the wrap looks like.
You got it. Yeah, it's all of those things, actually. So we get genetics. We get genetics on every patient. Because interestingly, the genome tells us so much. There are 450 different alleles that we pull. It will tell us what's the likelihood that they drink more heavy than others. Did they inherit this, from their family? Are their children at risk? These are hereditable issues, as I mentioned earlier. We take that genetic information. It also, interestingly, will tell us which medications are likely to work best for which patients. Wow. So naltrexone, you mentioned that medication. It's the most widely used, although it's not widely used. But of the medications used,
right?
It's the one that's often used.
Talk about it. Yeah,
exactly. Yeah. What's fascinating is if you get genetics, it shows you that about 60% of the people that get it in the US, it will work for. About 40% of people in the US, it won't work for them genetically. So if we don't get genetics, we're not going to know which is the right medication to pick for the right patient. So we do that. We then start them on one, again, there are several different kinds. There are about 30 different types. So we get a deep history about the patient. We understand any other medical issues, any other behavioral issues that they've struggled with, depression, anxiety, bipolar. And then we come up with a medication regimen that addresses all of those things. And then in addition, we actually have 20 different key nutrients that we place patients on. It's profoundly helpful to restore brain health. There's a great picture that I could show you of the brains if you'd like me to share it. I don't know if that would be. I don't
know if that will work on here.
Okay, I'm entirely open to trying. If you're open to me trying to make it
work. Go ahead and
try. All right, let's see if we can do it. It just sometimes a picture tells 1,000 words, right?
Yay.
So here are, normal healthy brain looks like this. This is an active firing brain. This represents a CAT scan of the brain with PET imagery that shows you activity in the brain. So this is how active a healthy brain looks. Look at what the brain looks like in someone who immediately stopped drinking 10 days ago, right? It's essentially completely shut down, maybe 5% activity, and the frontal lobes aren't working at all. And that's a really important thing to note, because the frontal lobes are where we learn, where we make our best decisions, where we think thoughtfully about our future. So when people
control, all of those. Yeah.
All the judgments that you were talking about in the very beginning of this program about, people being morally inept or, making bad judgments in their life. Well, it turns out the alcohol came first, caused frontal lobe problems, and the behaviors are actually secondary to the underlying brain disorder that's not getting addressed. So they go into rehab. Their brain looks like this after 10 days. They're there to learn. They can't. Their brain's not working well. 100 days after they stopped, look at the progress. There's almost no progress, right? Very little. It's about maybe 15 or 20% active. Isn't that something? So if we don't address this very important problem, with both medications and nutrient therapies, patients just won't get better. We have to send all of our patients a big kit. We send them all of these tools that they need to get better in our program. And I'll just mention right now, because we were talking about the nutrients, but we send the first 90 days of all of the nutrients that they need in order to help restore brain health. And what's been really fascinating is that we've learned that patients within 2 weeks, their mentation is dramatically improved. You can tell they speak clearer, they're doing better at work, their memory is improved. It's their cravings are improved. So within 2 weeks,
bandwidth then. For other things.
Yeah. So our program's a year and not a month. It's longer because a month, you can't get better from a problem that's this severe in a month. You just can't. So our program's a year long. So on the medical side, I've told you about the medications and nutrients. On the behavioral side, we decided to do something really inventive, and we began using virtual reality. We realized that group support offers benefit, right? But if you go into VR to do your group support, you are an avatar, right? You are completely actually anonymous. So the space behind me is one of our spaces, just to give you a sense for what that looks like. Yeah, we have about a dozen different spaces. You can literally sit around a campfire, But what's so great is that all the people there come in as an avatar and they feel a safety, to be able to share what's happening for them, ask questions. It creates a space that's quite healing.
Vulnerability. Yeah, I can see that.
They're led by our peer guides. We hire people who have lived experience, who are there to guide, and support those groups. And the really cool thing is we can do groups that are much more individualized, right? We have groups for veterans. We have LGBTQ groups. We have groups that are just for women with young children. They were hit really hard through COVID. So we can pick, specific subtypes and be able to provide care, because that's not something you can do in a community group. And this way people have more in common with each other than just having alcohol use struggles.
Okay, so what else? Do you have family supports involved in this? Because if they're home for these year doing this.
That's it. So important. We actually meet with them regularly through the treatment year. So right off the bat, when we initiate treatment, there's family meetings to help them know, what are we putting them on? What will this look like? They won't be stopping alcohol abruptly. They'll be tapering off, so they understand the why and what's the medical reason behind that. We go through the whole program with them, explain it, let them ask questions. Then we meet them again as soon as the person sort of moved to the next stage. We have 3 different stages in treatment. So once they've really stabilized pretty well, at least we've got them on the right treatment. We've used their genetics to help us, develop the right treatment plan for them. We meet with them again to say, this is where things are at, where they're doing well. Here's where we are. And then we meet with them again when they're in a continual care phase, when they've really come through it. At this point, they're just using all the tools, the medications are working, and they're doing well. And I'm really pleased to tell you that we have a 94.3% success rate.
Whoa, as opposed to 13 or 8%?
That's right.
94%.
94.3. Yeah. If there are, if 100 patients were sent to us, of course we will identify. So far, it's been about 8% of them. So roughly 8% of people, we will have to advance to a higher level of care for sure. Some people belong in what I would call like a hospital level of care, right? That makes sense. But of the folks we can care for that don't have to advance, we have a 94.3% success rate. It's actually remarkable.
Congratulations.
Thank you.
Congratulations.
Yeah.
I was thinking about it. We do a lot of talking about opioid overdoses, and I'm so glad that you have been part of that process of solution too. But alcohol deaths
Yeah.
are equally, if not greater, right?
Actually, they're almost 3 times greater. What's fascinating is that, of course, I'm very passionate about treating in the opioid space, right? My first 2 companies have treated 130,000 patients now. So they're, doing quite a bit of work. So I'm very passionate about that. But if you look at the numbers, technically, there are now 46 million people in the United States who meet the criteria for alcohol use disorder. It's enormous. It is 10 times the size of the opioid use problem, but it doesn't get the headlines.
No, because everybody wants to continue drinking.
That's it. People don't want to look at it.
Part of our culture. We live in a culture of alcohol use.
We do.
Culture. So
Yeah.
whenever we're asking somebody to stop using alcohol, we do have to understand we're asking them to swim upstream in this culture of ours.
Yeah, you're so right. You're so right. And, to that point, one of the things that we've developed is something we call drink substitution therapy.
Yeah.
And the reason we came up with it is that very point. People have to still be able to engage in their lives, in their communities, with their families, right? But they need a tool to be able to do that so they can bring a non-alcoholic version of their favorite drink. And, they look like a regular bottle of wine. It looks like a regular bottle of whiskey, so they can bring something with them and be able to participate in social events and yet not be consuming alcohol.
That's great.
Yeah.
So before we wrap up, what else would you like me to know about this? You've got great statistics, you're using genetics, you've got medication and a whole rubric of support. What have I not asked?
I think probably the most important thing that has to shift is the blame and shame culture.
Blame and shame.
And, I would say that, we often have described our company as founded in science, technology, and compassion. And I think that if you don't have compassion as one of those 3 pillars, you're not doing this work right. It's all about, people often talk about meeting a patient where they are. But the truth is they take patients out of where they are, they put them inpatient, they actually berate them quite a bit. And then they aren't at all where they are, and they're actually not even with people like them. Some people could be next to them with gambling use disorder or methamphetamine use disorder.
Or they're 30 years older or younger or whatever else it is. Yeah.
Nothing's meeting them where they are. So it takes a few weeks for patients who join us to develop the trust that actually we aren't going to berate them. There will always be compassion. It's a no judgment environment. If patients we don't even use the term, we never use the term alcoholic. It's derogatory. We don't even use the term relapse. It's also derogatory. We use the term if someone has a return to use.
Return to use.
Return to use. So it's like, Joey, you had a return to use this weekend. No problem. What was happening? Tell us about your weekend. Maybe you missed a dose of one of the medications, or, maybe it was just a really hard weekend and you could reach out to the peer guides next time. Let's try to be ahead of the game. So we give them strategies, but always compassion.
I love that. Well, Amanda Wilson, thank you for the work you do and for joining me today on Collegial Conversations. This has been enlightening, to say the least.
Oh, Diana, such a pleasure. Thank you for having me. I really appreciate it. And I'm so grateful to be working with you and the team at OPG.
Thank you.
Thank you.
Thank you for joining this webinar. Tune in to more webinars and sign up for our newsletter at o'connorpg.com.